episode number 2 of Neuroscience tutorial question and answer. Let's start with question number 1. A 67-year-old man is brought to emergency department by his wife. The man is lethargic, has motor difficulties, and cannot walk unaided. The history is provided largely by his wife, reveals that the man fell in his barn about 3 or 4 days ago. Had scalp laceration that is healing and is taking over-the-counter medications for headache. He is deteriorated significantly in the last 24 hours. CT reveals an extra-axial mass in the right hemisphere that has the same texture, gray color, and appearance as the brain. Which of the following would most specifically describe the mass in this man? A. Hyperdense. B. Hyperintense. C. Increased uptake. D. Isodense. E. Hypoechoic or echogenic. Answer key and explanation number 1. The correct answer is D. Isodense. The term isodense, hyperdense, and hypodense are terms that refer to the appearance of a lesion mass in comparison to the appearance of brain tissue in CT. The lesion that is essentially indistinguishable from brain, same color, texture, is isodense to brain, i.e. of equal density. Hyperdense refers to a shift towards appearance of bone more white or whiter than surrounding brain, while hypodense refers to a shift towards the appearance of the cerebrospinal fluid more black or darker than surrounding brain. Although the image produced in CT are obviously very different from radiograph, the principle behind CT is the same as for radiograph. But in radiograph, areas that are less dense, such as something containing gas, will allow more X-ray through, appear darker on radiograph, and are termed radiolucent, lucent, or of increased lucency. Denser structures block more X-ray, appear whiter on the image, and are termed radio-opaque, opaque, or of increased opacity. When a structure is of very high density, we might use a different descriptive term. If similar to bone, we often refer to as a calcified density. Examples would include renal calculi or vascular calcification. Surgical claps, staples, screws, pins, wires, plates, and joint prostheses may be referred to as being of metallic density and appear very white on the image. But in the second choice, we describe MRI image based on the intensity of the tissue or lesion in question. Structures can be hyperintense, i.e. more whiter than the surrounding brain, or isointense, has the same appearance of the surrounding brain, or hypointense, i.e. more darker than surrounding brain. Alternatively, we can describe them as being high signal or low signal. But in the C choice, we describe nuclear medicine image on the basis of increased uptake or occasionally decreased uptake. But when describing a PET scan study, FDG avid means increased uptake, and the patient with FDG avid disease show reduced overall survival, but patients with newly diagnosed tumor, which are often non-FDG avid, show only low intensity uptake. Nuclear medicine studies may be displayed as positive or negative image. Therefore, areas of increased uptake may appear as bright area on a black background or dark area on a white background. In each choice, the terms hyperechoic or echogenic or hypoechoic or isoechoic are used in ultrasonography. So echogenic, i.e. increased echogenicity, or hyperechoic image will appear bright on the image, but hypoechoic or decreased echogenicity appear relatively dark. The fluid containing structure reflect few, if any, of ultrasound wave. and are described as being anechoic. This will appear completely black on the image. Some lesions may be of almost identical echogenicity to surrounding tissue, for example, some liver tumors, and they can be described as isoechoic. When structure reflects all of the ultrasound waves reaching at, for example, bone or calcium, a very bright line is produced on the image, due to which everything appears black, so this appearance is called acoustic shadowing and is helpful when searching for gallstone or renal calculi. Question number 2. A 65-year-old man presents to his physician complaining of numbness in his hand. The history reveals that these deficits appear gradually and got progressively worse over several weeks. The examination confirmed a loss of pain and thermal sensation over the shoulders, upper extremities, and hands. Further testing reveals that vibratory sense and discriminative touch are normal over upper and lower extremities, and there are no cranial nerve deficits. Which of the following most specifically identifies these deficits in this patient? A. Alternating hemianesthesia. B. Alternating hemiplegia. C. Dissociated sensory loss. D. Paresthesia. E. Tactile agnosia. Answer K and explanation number 2. The correct answer is C. Dissociated sensory loss, because a loss of pain and thermal sensation with sparing of the posterior column modalities, i.e. vibratory sense and discriminative touch, constitute a dissociated sensory loss. Such deficits are most frequently associated with spinal cord lesion and may be the opposite of that described here. Loss of the posterior column modalities and the preservation of pain and thermal sensation. The patient has syringomyelia in cervical level of spinal cord, and this is the classic sensory loss in Cape distribution. The loss of the sensation on the body with sparing of the cranial nerve also localize the lesion to spinal cord. On the other hand, alternating hemianesthesia is the loss of the same sensory modality on one side of the body and on the opposite side of the face, also called crossed hemianesthesia. But an alternating hemiplegia is a corticospinal deficit motor or one side of the body and a cranial nerve motor deficit on the opposite side, also called crossed hemiplegia or steroplegia. Paresthesia refers to the spontaneous occurrence of tingling, tickling, pricking, numbness, or burning of the person's skin, or abnormal sensation in absence of the actual stimulation with no apparent physical cause. Stereognosis or tactile agnosia, if only one hand is affected, is the loss of the ability to recognize objects by touch without other sensory input, i.e. eyes closed, when the peripheral nerves are intact. Question number 3. A 55-year-old man is brought to the emergency department after collapsing at his place of work. The initial examination reveals a slightly overweight male who is somnolent with a profound weakness of his right extremities and a loss of all sensation, pain, and thermal, discriminative touch, vibratory sense also on his right side. Cranial nerve function is normal. Re-examination at 6 hours confirms this structure and shows a further reduced level of consciousness. Based on this observation, which of the following represented the most likely location of this lesion? Forebrain, A. B. Midbrain, C. Medulla, D. Bones, A. Spinal cord. Answer key and explanation number 3. The correct answer is A, forebrain, because lesions in the forebrain are generally characterized by motor and sensory deficits, all modalities on the same side of the body, in absence of the cranial nerve deficits. This is one of the main examples of the general localization of CNS lesion. Such lesions may be located in the caudal thalamus, posterior limb of the internal capsule, or overexpansive area of the cerebral cortex. Also, Large hemisphere lesion may but not always have some facial weakness. However, the latter may be quite large and result in an instantaneously unconscious patient. Normally, there may be variation on the theme, namely some cranial nerve involvement if the lesion extends to the genu of the internal capsule and if the patient can be tested to confirm this. On the other hand, lesions in the brainstem shows B, C, and D characteristically persons with alternating or cross deficits, long tracts, such as corticospinal signs on one side and cranial nerve signs on the other side. In addition, brainstem lesions, especially those in the bone and medulla, rarely produce somnolence. But spinal cord lesions are usually characterized by alternating motor and sensory deficits that have motor and sensory levels start at specific dermatomes and include all the dermatomes below, but with no cranial nerve signs. Question number 4. A 65-year-old man has sudden weakness on his right upper and lower extremities, but he has no other symptoms. Which of the following is the most likely cause of this mass deficit? A. Acute bacterial meningitis. C. Convexity meningioma. C. Glioblastoma multiforme. D. Intracerebral hemorrhage. E. Subarachnoid hemorrhage. Answer key and explanation number 4. The correct answer is D, i.e. intracerebral hemorrhage, ICH, because the sudden onset is the hallmark of hemorrhage event, especially in absence of other symptoms. Intracerebral hemorrhage, ICH, is caused by bleeding within the brain tissue itself. It is a life-threatening type of stroke. ICH is most commonly caused by hypertension, arteriovenous malformation, or head trauma. But don't forget that substance of the brain has no pain ending, so the event has no pain specifically. On the other hand, subarachnoid hemorrhage, SAH, is also sudden onset but with sudden and excruciating headache. Blood vessels have pain fiber, i.e. pain sensitive. SAH may occur as a result of head trauma or spontaneously, usually from a ruptured cerebral aneurysm. Variety of signs and symptoms, including focal ones, may appear within hours in subarachnoid hemorrhage, SAH, like vomiting, decreased level of consciousness, fever, and sometimes seizures. Neck stiffness or neck pain are also relatively common. Females are more commonly affected than males. Acute bacterial meningitis is rapidly progressive bacterial infection of the meninges and subarachnoid space. Findings typically include headache, fever, and neck rigidity. Diagnosis is by CSF analysis. Treatment is with antibiotic and corticosteroids, given as soon as possible. It has a rapid onset but takes a few days to become symptomatic. Glioblastoma multiforme is a rapidly growing tumor but may take months to produce signs and symptoms. Meningioma at any location is benign tumor and almost always develop very slowly and may take years to become symptomatic. Question number 5. Considering the full range of possible treatment, surgery, radiology, chemotherapy, a patient with which of the following tumor would most likely have the longer survival? A. Anaplastic astrocytoma. B. Brainstem glioma. C. Glioblastoma multiforme. D. oligodendroglioma. E. meningioma. Answer key and explanation number 5. The correct answer is E, i.e. meningioma. Because meningiomas arise from arachnoidal cells, most of which are near the vicinity of the various sinuses and are generally slow-growing extraaxia located outside brain substance, i.e., and therefore non-invasive and are frequently benign. Women are affected about twice as often as men. The most common treatment is surgical resection. Transarterial embolization has become a standard preoperative procedure, and if the entire tumor can be resected, the cure may be completed, but following complete removal, less than 20% recur. If surgery is not possible or all the tumor cannot be removed, radiosurgery may be helpful. Chemotherapy has not been found to be useful, but a small percentage of the meningiomas grow rapidly and are associated with worse outcomes. But if total resection is not possible, survival may still measured in many years due to their slow growth, so the 5-year survival rate is over 90%. Many individuals have meningiomas but remain asymptomatic, so the meningiomas are discovered during an autopsy. Brainstem glioma are commonly seen in children or young adults. More than 75% are less than 20 years of age. They start in the brain or spinal cord tissue and typically spread throughout the nervous system. They are difficult to treat surgically due to complications in the vital parts of the brain and usually don't respond to chemotherapy but may respond to radiation. The brainstem glioma is an aggressive and dangerous cancer, so with appropriate treatment, the patient may survive 6 to 15 months after diagnosis. But without treatment, the life expectancy is typically a few months. Both of anaplastic astrocytoma AA, WHO grade 3 to 4, and glioblastoma multiformes GBM, WHO grade 4, are malignant, invasive, high-grade gliomas and somewhat responsive to radiation and chemotherapy. GBM is the most aggressive cancer that begins within the brain, and it is the most common cancer that begins within the brain and the second most common brain tumor after meningioma. GBM occur more commonly in males than females. In anaplastic astrocytoma or AA, radiation therapy has been shown to prolong survival and is a standard component of treatment. GBM treatment involves surgery, after which chemotherapy and radiation therapy. The medication temozolomide is used frequently as a part of the chemotherapy. High-dose steroid may be used to help reduce swelling and decrease symptoms. Immunotherapy is being studied in glioblastoma with promising results. These tumors are not curable. Survival for AA may be up to 18 to 24 months, and for GBM is a range of 6 to 12 months. Oligodendrogliomas, ODs, are usually adult malignant tumor, represent 9.4% of all primary brain and spinal cord tumor, but are also found in children, represent 4% of all primary brain and spinal cord tumor, most frequently found in the white matter of the forebrain lobe, frontal lobe, and their first symptoms are seizure, then headache. The choice of treatment is chemotherapy, favorable response, followed by surgery in some instances. Survival rates are in the general range of 2 to 4.5 years, but may longer in some cases.